Hey folks, welcome back to the channel. My name is Drew. If it's your first time here, a big welcome. In this series, we are studying, learning, exploring functional anatomy, which means understanding how when the muscles contract, how they move the bones, so how movement is created, so functional movement anatomy. And the way we do that is we kind of do what I call the Lego process. So you kind of look at each individual muscle on its own, and then you kind of put them together and create like your Lego building or your structure with the small blocks and pieces putting together, right? So when you go learning anatomy, there's a lot to learn. There's a lot to kind of wrap your head around, and there's not really any kind of quick way of doing it. You just got to be really methodical and just work your way through one muscle at a time, one ligament at a time, one joint at a time, and then slowly it all just kind of like comes together. Okay. So the whole idea of this series is to kind of help people with the way they learn so they can kind of appreciate some of the more nuances of it. So you can get these apps, but there's a lot of things that they don't explain in the apps, a lot of context. So hopefully I can share you more of the context-based stuff because the apps are great and we're using 3D for medical complete anatomy, which is an amazing tool. But like all tools, you know, there's like little tricks and nuances and techniques that we can learn. So in our series, we're looking at the abdominals, and in a previous video, we did the rectus abdominis, and I'll try to link it above here somewhere if I can figure out how to do that. And then today we're going to look at this muscle here, which is called the internal oblique. Really, really important muscle in the core. And you'll see why as we kind of go through it here. So we start always with our origin and insertion. So if we come across onto the left, under info, quick facts, we've got origin, the thoracolumbar fascia, iliac crest, and inguinal ligament. So let's have a look at what that means. So the thoracolumbar fascia, so if you get stuck in anything, all you do is come over to the right here in the search term and just type in the name of the structure you're trying to find more about, thoracolumbar fascia. Let's see, it should pop up. There we go. And so the thoracolumbar fascia is this really strong connective tissue in your lumbar spine, in your lower back. All right. And it connects into the latissimus dorsi coming up through here. So your internal oblique attaches to the big back ligament, if you will, kind of like this is like a ligament. This is like the ITB band, but in your lower back, really strong. It's a really strong weight bearing, load supporting kind of tissue. And so it literally connects to your core muscles on the side here. So that's the thoracolumbar fascia. And then we just got the fascia that extends up. This is the posterior back line. When we look at kind of fascial anatomy trains, that will go into that in a lot of detail when we do fascial trains. Fascial trains are really important because that's where the acupuncture meridians live in Chinese medicine as well. So we'll get to that. But before we learn all those really interesting, cool things, we want the fundamental knowledge, and the fundamental knowledge is skeletal structure, muscles, joints, tendons, ligaments. So we're going to do all the foundational stuff first. Because if you jump too far ahead, it kind of like you can get really lost and things won't make much sense if you jump too far ahead, if you don't do the foundational kind of preparatory work first. So I've got no shortcuts, there's no quick routes. You still have to do the study, you still have to learn this stuff, right? So that's the fascia, thoracolumbar fascia. The iliac crest is this kind of line on the top of your pelvis, on the top of the ilium. So the green part here, this is the ilium there of the pelvis. This is the pubis here. And then this is the ischium on the back of the pelvis. So here we have the ilium, and this is the iliac crest. So basically from the side, the top point of your iliac crest is going to meld into the thoracolumbar fascia, becomes the internal oblique. So they kind of like mesh into each other there. So you have this big, strong structural attachment on the pelvis. Then we attaches onto the inguinal ligament, which is this really big ligament here. If we come up, you can see it's quite thick. It goes right down onto the pubic bone here. So this is like a nice structural support ligament. And so your obliques attach onto that line there. Now it's gonna connect into the rectus abdominis here as well. So it'll be a fascial connection with the anterior abdominal wall. And so then you'll also get tendinous attachment onto the pubic symphysis here with the rectus abdominis. So they're basically gonna connect into each other like that. So the rectus abdominis will sit on top and the internal oblique will be underneath. So that's your initial attachment. So it's quite a big attachment. It wraps around from the front to the side, and following the line of the thoracicolumbar fascia goes into the back as well and onto the sacrum. So this is all one inner unit, if you will. You often hear that term when we talk about core, in and outer unit. Then if we look back to our insertion, inferior margin of the 10th to 12th ribs and adjacent costal cartilage. So inner margin of the 10th to 12th rib. So that rib there we've got is 11, 12, 10. So bottom of the ribs, plus the costal cartilage through here as well. So we'll put the costal cartilage in as well. Costal cartilage. So we're attaching onto the ribs here. This is important too, because in like respiration, we have a lot of movement in the bottom part of the rib cage, and a lot of that movement comes from the flexibility that's given from the costal cartilage. So costal cartilage is really strong connective tissue, but it has some flexibility, it has some movement to it. So we can breathe in and out, and we have a little bit more kind of leeway of getting air in and out of the lungs. This becomes important in exhalation phase, because what we'll see is that in conjunction with the rectus abdominis, the internal oblique is going to contract. If you follow the lines of the fibers, you can kind of see it's going to pull these ribs down inferiorly this way, and the side ones here are going to pull down as well. So we're getting this kind of inferior line of the pull coming down. So these muscles are definitely involved in exhalation phase of breathing. We also then have the adjacent costal cartilage and the linea albia and the pectine pubis. So the linea alba is the line that comes right down the middle. So if I put back in the rectus abdominis, actually let's just put in the linea albia. The linea alba. So this is a little bit of connective tissue that comes right down. It's kind of similar to like this ligament here. All right. And so on the side, you're going to have the two lines of the six pack or the rectus abdominis come down either side. This is a really important acupuncture meridian in Chinese medicine. So this is what's called the conception vessel. So you have a very powerful energy line that comes up through here where the chi or energy flows through there. But again, we'll get into that in another video. But just to kind of note that if we put in now the rectus abdominis, rectus, sheath, muscle, sheath. Oh, don't know what that is. Out of the way. Rectus abdom. Gotta spell it right. That's always helpful. Here we go. So we put the rectus abdominis back in here, and so you can see that the abdominals connect to the linea alba, that long strip kind of thin connective tissue line going down the front. So the internal oblique on the inside here, get rid of this one here, the external oblique, let's hide that, is going to connect via the rectus abdominis into that internal line. So what that means is when you contract this muscle, so for example, if you look at this fiber direction coming almost horizontal, if you do an abdominal brace and you contract isometrically, this muscle is going to basically tension, and that's part of its stabilization role. All right. So when you contract, and if the muscle's contracting evenly, you're getting muscle fibers pulling down this way, this way, this way, this way, this way. Essentially, nothing really moves. It becomes an isometric contraction, and that creates the stability So that's going to compress all the abdominal contents here into the spine. And at the same time, you've got the lower back muscles and the thoracolumbar fascia contracting as well. So everything kind of gets tensioned. And then you've got this kind of 360-degree bracing that occurs with the abdominals as well. So when you hear transverse abdominal bracing or abdominal bracing, what we're talking about is we're tensioning these muscles, they're contracting and engaging isometrically, but we're not really moving the ribs much, we're not really moving the pelvis much, we're not really moving the spine much. Everything, all the major joints are essentially staying where they are. There'll be a little bit of movement as you tension things. There will be some, like there'll be a little bit of depression of the rib cage, but you're essentially not making great amount of movement. So that's important when you're stabilizing yourself for balance, or when you stabilize yourself when you're going to lift or push a heavy object. So imagining you're lifting a deadlift, barbell off the ground, or a heavy wheelbarrow, or if you're doing a push-up, or if you are going up a flight of stairs and you need stability, particularly on one single leg stance, which is really important for this muscle here as well. So core training is really, really essential. And it's not so much, the muscles aren't so much about being super strong, they're endurance-based muscles. So you want lots of good repetition and really focusing on good posture and position. So when they contract, they can do their job correctly. Okay, now I'll go back to this one. We'll leave the six-pack muscles there for now. We're back on info. And the pecten pubis, which is the pecten pubis down here. All right, so really big muscle. Essentially, what you want to look at is like, you follow the line of the ribs from front to back, and you follow the line of the pelvis, front to back, all right, to where that ridge is there. Okay, and then right down the middle, everything in between that, all this empty space is abdominals. Okay, and this is going to be mainly internal oblique. Okay, action. It's going to flex, laterally flex, and rotate the trunk, compresses and provides structural support to adjacent abdominal structures. So it's going to work with all the other abdominal muscles, rectus abdominis, external oblique, which we'll do another video about soon, internal oblique, and transverse abdominis. So they all work together. And there are really one way to kind of look at it is there are 6 ways of how the spine moves. So there's flexion extension, so forward bending and then backward bending, lateral flexion to the right and to the left, rotation to the left and to the right. So forward, back, side, rotate. So that's 4 movements. We count lateral flexion to the left and lateral flexion to the right as 1 movement. And then you have abdominal bracing, so tensioning the muscles and bracing the core. And then you have what's called anti-rotation. So if you stand on one leg, okay, all these muscles here are going to be engaging to not only stabilize you, but to stop you from twisting excessively. And because if you rotate excessively, your center of gravity changes position. And when your center of gravity, which generally sits about here, comes outside your base of your support, which is your foot. Okay, usually around here. Okay, if it comes out of your base of support, then your weight comes forward and you will lose your balance and potentially topple forward. So that's anti-rotation. So that's all based on kind of gait and walking patterns. So the core's got a lot of, the spine has to move a lot of ways, and the muscles that move the spine is the core and the spinal muscles. They all work together. So it's actually quite complex when you start to kind of put it all into position. And then each individual vertebrae can move, and then the pelvis can tilt forward and back, anterior and posterior tilt. And it can have this kind of like lateral tilting as well. And it can do a sinusoidal kind of like a figure 8 rotation as well. And then you can have anterior and then posterior rotation or translation forward and back. So there's a lot of things that can happen in the pelvis. And then the sacrum, which sits here, the whole spinal column sits on top of the sacrum, and then the sacrum sits within the pelvis. So anytime you move the pelvis, you're going to move the sacrum, which is going to affect the spine. Anytime you move the spine, it's going to move the sacrum, which is going to affect the pelvis. So they're kind of like interlinked, intercoordinated. So movement at a really high level, when you're understanding movement particularly, And when you integrate the pelvic floor as well, is you want to integrate all those muscles together in all kinds of different movements. And that's where it gets quite complex and quite tricky. But once you understand the anatomy, it makes a lot of sense. So you can kind of figure it out, which is really cool, which is one of the reasons why we're doing this, right? So back to our anatomy lesson. Artery supply, we don't really need to be too concerned about arterial supply, particularly in what we do as movement professionals. I'm looking for the innovation. Well, innovation here. Anterior arming of the 7th to 12th thoracic nerves, iliophagastic and iliolingual nerves. So essentially what that means is that you've got nerves that are coming out at different segments of the spine. Okay, so you could potentially have like an injury to one of your nerves higher up because you got multiple levels of the nerves. You're still going to get innervation to the abdominal walls, which is really, really good. So you've got backup. So if one section of your spine gets injured and the nerve gets compressed or compromised, then you've got other nerve supply, which is going to help contract and keep that muscle engaged. So that's one way we can kind of rehab a lot of folks, is even though one area is compromised, we can still work with other areas, which is pretty cool. Okay, let's have a look at motion. So 3 key movements it's going to show you here, and there's another one that I'll talk about as well, which is not displayed here. So let's look at the first one, lateral flexion. We're going to fade all the other muscles. So here we have, this is an anterior view because you've got the sternum here. So now when the pelvis is fixed, as in like the pelvis is not going to move. Okay, so imagine you're sitting on a bench. Okay. All right. When these muscles contract, it's going to pull you straight to the side. So this is lateral flexion here. You can see these fibers here coming on a downward angle. So we're really working on these particular fibers here. You're going to get some of these fibers coming down this way as well. When we look at the external oblique, there'll be other fibers coming from the opposite direction coming across this way. So you've got like this crossing. And so they'll be working together as a unit to create this side bending or leaning out to your side. You're also going to be getting your quadratus lumborum muscle working. Where is it in here? Quadratus lumborum. That's the right, let's do the left. So our QL muscle here, pulling down. So that's your lateral flexor there as well. Let me put it back on the right so you can see it. There we go, this one. So QL here. So this is how you stretch your back as well, right? So if you want to stretch your back, okay, everyone's got tight lower back. So because of reciprocal inhibition, okay, when you contract this left quadratus lumborum, okay, there will be a nerve supply connection that goes from the muscle to the spine and then out to the opposite muscle. And so to allow this movement to occur, this right QL has to relax to allow you to be able to lean out. If it tightens up or contracts, it will stop the movement. So that's called reciprocal inhibition. So if you want to relax your lower back, okay, what you need to do is contract opposite muscle. Okay. So if you do this with intention of just squeezing this muscle here, okay, that will then help relax this. Then this muscle will then get stretched or lengthened. Now, if you do this in a standing position, because gravity is coming down this way, okay, well, now we're actually going to get what's called an eccentric contraction of this muscle here, okay, because it's going to be working to stop you from tipping over eccentrically. So this muscle here kind of starts it, but you'll see that it can only go so far and it runs out of space. But then you've got the weight of the torso going down this way. And so all these muscles here, the QL and the ab muscles on the side here, are going to get tensioned. And they're going to be the ones that are going to be responsible for keeping you upright so you don't fall over, but also to actually pull you back upright to this position here. So position is really important. So if this is standing, if you lean out to the side this way, so I'll come back. If you lean out to the side, this muscle is going to start contracting. The center of gravity is going to start to shift across. At some point, the weight of the torso will take over, and these muscles don't need to contract as much, or they'll run out of room, depending which one comes first. Then as you keep going over, now these muscles here are going to start lengthening under tension, and they're going to start controlling the movement. So that's going to stretch out. And the best way to develop flexibility in a muscle is to lengthen it under tension or eccentric contraction, okay? Because you're getting lots of neurological feedback into the spinal column, into the spinal cord. And so there's a lot of communication to the brain. And then it's also going to strengthen this over time, because eccentric loading is a great way to strengthen muscles. So that's a really, really good way of developing that strength in the lower back, okay? Creating that nice lateral flexion. Now, if we take that concept, let's look at the next movement. This is the turning. Okay, so we'll flip it around here. So we've got the obliques. Sorry, there was just someone knocking on the door, but my partner got it, so all good. Now let's fade all again. Okay. So here, if we look at the 5 direction, unfortunately, it's difficult to see here, but you've got the attachments coming through there. Again, the pelvis is fixed and stabilized. This time, the fibers that are kind of moving in this upward direction through here, they're pulling it across, and that's creating rotation. At the same time, you're getting these lower fibers pulling in a little bit. So that's going to help create that rotation there. The opposite side in the back, here you're going to have other muscles contracting to pull you around. So if you're coming down this way, the lat muscle is going to be pulling you down this way here to get that rotation through there. Now it can go the reverse direction. So if we come back to the middle, now assuming you're lying on your back and you're back here, you're right in the middle, come back to the start. Assuming you're lying on your back now and you're in like a T shape, arms stretched out, your side palms are up, and you're going to bend your knees up. You're going to do a windscreen wiper with your knees bent, so either on the floor or in a tabletop position. So what would happen there, instead of the torso rotating, the torso is fixed, and then the pelvis rotates. So you kind of get this kind of twisting through the hips and the lower back. And so you, in that way, you're going to get really good strengthening and stretching of these kind of back muscles here again, the QLs, but you're also going to be using these obliques to rotate. And it's typically the one that's on top. So if you rotate this direction, this muscle's on top, that's the one that's going to be working against gravity. So they're the ones going to be working to kind of pull you back into the middle. So kind of the supine knee rotations, where you're just rolling legs side to side, they're a fantastic way to start to integrate and develop oblique rotational strength. Okay, so I typically will start clients lying on their back, their knees bend up with a very gentle rotation, and then cueing correct breathing techniques. When you breathe correctly, it helps facilitate the abdominal contractions. So that's just something to be aware of through there. Also keep in mind too that the opposite obliques will be working with you to create the movement. So here you'll have the external obliques coming down, and they'll be contracting in the opposite direction. So they're going to be coming up this way, and they'll be pulling you down this way too. So you get 2 muscles creating a twist, 2 muscles creating a twist. Okay. And then if we go into, you can see all these muscles, all these muscles are involved in rotation. Okay. So twisting, even if you look at like psoas major. Okay. So that's it. Psoas major is right. Let's bring it on. Maybe not there. Psoas major. No, it's not showing up. but even psoas major is a kind of it has a role in flexion of the spine and twisting because it comes onto the vertebrae on the side through here. So you can think about your hip flexors. I might go back to the other diagram to show you that properly, but you can think about with hip flexors attaching through here, the psoas. If the left psoas here contracts, it's going to actually laterally flex you to the left, and that will then stretch the right psoas as well. So how we stretch the psoas is a little bit of a posterior tilt, and then you laterally flex the opposite way. Okay. So internal oblique, and then we have the classic trunk flexion. So this works when both of the left and right internal obliques are working with the rectus abdominis. You get the classic sit-up kind of position. And so all the kind of points regarding flexion of the spine that we talked about in rectus abdominis, remember we had the 4 different types of sit-ups you can do. So there's the trunk flexion where the ribs are pressed down. That's one. There's the posterior tilting, okay, where you roll the pelvis. That's the second sit-up. There's the neutral one where you can do the sit-up but maintain the neutral shape. So you maintain the curve here, you still contract the muscles, you still roll up, but you don't change that shape in the spine there. And then the fourth one is where you do the flex the spine to flatten the lower back, you tilt the pelvis posteriorly, and then also you depress the ribs down, and then you get the full contraction of the abdominal wall. That's your full sit-up. And if you're doing exercises like hollow outs, that's the shape that you create. That's the strongest position that you can create with your core muscles. And so when you're doing hollow out positions, either on your back or in a plank position, we do that because that's the strongest position you can get your core on. So everything is on, including the extensors of the back, hip flexors, anterior core muscles, rectus abdominis, internal external oblique TV. They're all on. And if you breathe correctly, then you can turn on your pelvic floor muscles, and also using your diaphragm as a respiratory muscle, but also a primary stabilizer of the spine. So you have a very strong, rigid spine. And so when you look at people like powerlifters and like the kind of the weird shape they place their spine when they do bench press, what they can do is just like create a really strong, rigid skeletal structure that they can push a lot of weight from. So it has to be really stiff. So really stiff to do that. Some movement, like all the twisting, rotation, like if you play tennis, you want to be able to rotate and twist. If you play golf, you want to be able to rotate and twist. So you don't want a very super strong, stiff spine. You want a flexible, supple spine. So sometimes our training goals really depending upon individual goals or what people's activities or sports are or their work role, and then we can train around that or keeping that in mind as well. So everyone's a bit unique and a bit different depending on what their goal is. So that's the movement of the hip flexors. Now, let me just put in the psoas here so I can just show you that quickly. Oh, I was wondering where it was. Connective tissue, major left. Let's put in the right one. It's better. Okay, so you can kind of see here our psoas muscle attaching onto the anterior bodies of the lumbar vertebrae 1 through to 5 and onto the transverse processes of the lumbar spine 1 through 5. So if this muscle contracts here, it's going to pull on the spine in this direction through here. So if you're doing like a side plank, you're going to get your internal obliques on this side contracting, but you're also going to be using your hip flexor to contract as well. Okay. Now, a lot of people who have back pain have a very, very tight hip flexor. It's a very common presentation, not everyone, but it's very common. And the reason for that is such a powerful muscle that when people hurt their back, for some folks, the way the back responds is to create an arch or an anterior tilt, or just to shift the position of the spine to get off the point of inflammation or the point of irritation or injury. So then that whole spine changes its shape and the body changes its shape to kind of like take pressure off that injured structure. And then the muscles around the spine kind of like contract strongly to kind of just maintain that shape and to prevent you from going onto the other side. And if that's really normal in the early phase of any injury, that's a protective mechanism. But what happens is if we don't then restore the muscle position and basically say, hey, it's okay, it's safe, the tissue's healed, we can go back to where your normal role, your normal position, they can persist. And if you've got a really tight hip flexor, let's say example, the right side's really tight, it's going to pull your back forward. So that creates the arch, that creates the lumbar lordosis, and downward. So it kind of like creates a compression in the lower back. And if it's one side, depending on how people present, it's going to lift the entire pelvis up a little bit. So you get like this uneven pelvis position. Or it's going to create a side bend here and create a scoliosis, which will then tilt the hip the opposite direction. So it can go the other way. So it just depends on people's presentation. Then it will spasm it and lock it down. And then these segments here don't move very well and get nourished. So then that impairs the healing. And then when you get an anterior tilted pelvis with this kind of uneven kind of patterning, you get a lot of muscular, not so much imbalance, but like they're just not communicating. You got muscles that are put in a short position, so when they're tight and they're short, they fatigue easily. When muscles are then the opposite muscles will be put in more length position, so they're going to be weaker, so they won't be able to contract it in a stronger, more functional way. So that creates this uneven kind of force production through the tissues. And so that way you can kind of get impingement kind of conditions and jamming and just all kinds of problems. So the psoas becomes a really, really important muscle in back rehabilitation for a lot of folks because it just is such a powerful protecting muscle, but it's also a really powerful movement muscle. So we need to basically switch its role from being protector to back to a primary mover. And there's a whole process that we need to step people through to get to that. If you start strong hip flexor work too early, like leg levers, so you're lifting your leg up, hip flexion, or kind of like big sit-ups type movements, that's going to put a lot of torque pressure pulling on the spine. And if it's too early, it might be too strong, and you might actually get like a counterproductive kind of work through the core there. Particularly if these abdominal muscles in the front, the anterior core, have not been restored to a good function and good position, because then they can't do all their stabilizing and movement roles that are necessary. That can then trickle up into respiration, because then if the pelvis is anterior tilted, the lumbar spine is anterior tilted, okay, that creates a chest lift, all right, which lengthens the abdominals on the front, okay, and then that puts the diaphragm in a very poor position to contract fully, so you can't get a full breath in. The chest is lifted, that then over recruits the neck and the traps, and then you get neck and shoulder issues and potentially shoulder impingement, all kinds of stuff from that. So that can all translate up the body into the neck and shoulders. It can translate in shortness of breath, not being able to get a full breath in or a full breath out. So that can affect your mental and emotional state, because breathing is very closely connected to how your mind and your emotions are regulated. And then, of course, then it will translate down into the legs and how the legs are positioned, because the femur, the leg bone, sits in the pelvis. So when you move the pelvis, it changes the orientation of the femur, and that changes the orientation of the kneecaps to the front. And one of the key things that the body's trying to do is trying to keep your knees in a straight line to the front so they can hinge properly. And so then the body will compensate and try to pivot the body around its axes, so you can kind of maintain a nice knee forward position, because the knee's got a very limited range of movement. It basically just goes forward and back, a little bit of twisting or rotation, but not enough. So it kind of needs to be set in the kind of the sagittal plane, the forward and backward plane, so it doesn't kind of stress the knee out. So, so you can see how it kind of moves up and down the kinetic chain, up and down the body, and it can be quite tricky to kind of resolve for people. So issues of the knee or the shoulder are sometimes really kind of created through the lumbopelvic region here. And in my experience, if you can get people to be very functional in terms of how they use their core muscles, teach them how to use their pelvis, so to when to tilt and roll the pelvis with movement, and then how to use the shoulder blades correctly to position the shoulders. You get those three things working well with correct breathing techniques of 4 key essential elements, then 90% of movement issues are basically fixed or resolved. Case in point, I had a client today who had a pretty bad rotator cuff tear. Just told that she needed surgery on that. She didn't want to do surgery because she works for herself, and she couldn't afford to have 10 weeks off of the surgery and the rehab that they were telling her. So she kind of came to me in hopes that I could give her some guidance and advice. Fast forward 5 weeks, we've got her back to full range in her shoulder, pain-free, off all medication. We started actually doing overhead dumbbell pressing today, pain-free, full range of movement. And and it's just by retraining functional anatomy and slowly stepping people through the progress. So, helped this lady prevent a shoulder surgery by just teaching her how to use her core, how to breathe, and then how to use the shoulder itself properly with movement. And she became her own therapist. I did a little bit of manual tissue work on her on the table because she just had some big trigger points through this region, through here and in the rotator cuff. So I need to let them go. But then after that, after a couple of sessions on the table, integrating in stretching, self-myofascial release, mobility and strength exercises. She's pretty much full range shoulder, and we'll get her back into CrossFit pretty soon. So she's gone from having to give up CrossFit entirely, having to go do a surgery, like 10 weeks of surgery, and then probably a full 12-month rehab program post-surgery to get back to CrossFit. Now, in less than 8 weeks, we've got her pretty much well on track to get it back into her classes, which is what it's all about. Anyway, so that's probably enough of me talking for one day. If you're enjoying the videos, leave me a comment, like and share, do all the good things. Let's share the knowledge, share the information. If there's anything I've missed you think might be useful, whack it down in the comments. Really appreciate when people say, hey, Drew, how did you think about this? Or you missed this piece. Let's go. Let me know, because you can tell basically I'm just doing all this off the cuff, just from my base knowledge. So I could sit down and prepare full presentations, but I just like to talk about what we're doing in anatomy. I've been teaching this stuff for a fair while, so it's just fun. Anyway, so wherever you are, keep studying, keep learning, keep growing, keep training, breathe, and stay humble. And we'll see you in the next video. Ciao.